Hi everyone, welcome back. In today's video, we're going to go over PALS, which is Pediatric Advanced Life Support. So this is the entire algorithm. It may look a little too much, but we're going to go through each part, breaking it down and make it really simple for you guys. It's very similar to ACLS, it's just different in terms of like the dosing and little differences here and there. So first of all, when are you doing PALS? So if you find your pediatric patient non-responsive, that means they're not breathing and they don't have a pulse, or their pulse is less than 60. This is what differentiates from ACLS, right? ACLS, if they have a pulse, then we're not going to do all this. But in pediatrics, since their pulse is generally way higher than adult, if it's less than 60, that means things are bad. Okay, so less than 60, they're showing signs of, poor perfusion and they're not breathing, non-responsive, then we're going to start CPR. So CPR, it's a little different in pediatrics, is that what's the depth? So in adults, we do 2 inches. In kids, we do a third of their anterior posterior diameter. So you measure, you put one hand at the front of their chest, one hand at their back, and that width is their AP diameter. So you take a third of that, and that is the depth that you're going to be going with your compressions. Now, these compressions have to be fast. As we said, kids require a higher heart rate than adults. So try to get it to 100 to 120 beats per minute. And then what is the ratio? So in adults, we said it's 30 compressions and then 2 breaths, right? In kids, it's going to be 15 compressions to 2 breaths if there's no advanced airway. So if advanced airway is like a supraglottic airway or endotracheal intubation, if you don't have that, you're doing 15 to 2, because it's very important for them to get respirations. But if you do have an advanced airway, then you just do continuous compressions. There's no ratio. It's just constant CPR, and you give them breath every 2 to 3 seconds. You're administering a breath. So that is the difference in CPR. So once you're starting CPR, someone got the AED or you got the defibrillator, you hook them up to a monitor. You have to check, is the rhythm shockable? Most important question. So what situations would the rhythm be shockable? If they're in VFib or pulseless VTAC, right, which looks like this. And it would not be shockable if you have asystole, which looks like this, or if they're in pulseless electrical activity, meaning they don't have a pulse, but there's somehow electricity showing normal quote-unquote rhythm on the monitor. So it doesn't really matter what the monitor shows, they don't have a pulse. So that's why it's called PEA, it's a condition. So let's start on the left first. So if you can shock them, that means they're in VFib or pulseless VTAC, you administer the shock. Okay, so what is the shocking dose? This is very important. So the first shock we administer with a weight-based dose, 2 joules per kilogram. So if they weigh, let's say, 11 kilograms, then the first shock is going to be 22 joules. Okay, if you are giving them the second shock, it's going to be 44 joules. And the ones after that, it's going to be greater than or equal to 4 joules. And the max you could go up to is 10 joules per kilogram. So let's go back up here. So first, you see that they're in VFib or pulseless VTAC. Administer the shock based on this, right? Then as soon as you give the shock, continue CPR. That is a must, right? Continue CPR for 2 minutes. Have someone establish IV or IO access, because we're going to have to push meds soon. Then after 2 minutes, check it again, right? If they're still in this rhythm, then you give them another shock, right? It's going to be 4 joules. Now, right off the bat, continue CPR. Now that you already got IV and IO access, you want to give meds. So first med we always give, we start with epi, right? Epi is every 3 to 5 minutes. I just make it easy, 4 minutes. And what is the dose? The dose is 0.01 mg per kg. And if you have a concentration of 0.1 mg per ml, then the dose is going to be 0.1 ml per kg. So that's a very easy one. And once you give the epi, you're also having someone set up an advanced airway just to make things go smoother and really make sure they're getting those breaths. Then after that, give another shock. After that, continue the CPR, and now we switch med. So you give amiodarone, or lidocaine. So the amio dose, remember, it's different from adults, which was the same dose for everybody. Here we give according to their weight, so it's going to be 5 mg per kg for the amio, and you could give max 3 doses of that, and lidocaine is going to be 1 mg per kg, easy. And at this point, you should already be starting to think about the H's and T's, which we went over in the ACLS, so you could look to that video to see the H's and T's. You could just pull up any chart on the internet. I'll insert one over here. It's just something you have to memorize, but you'd have to be thinking about those things. Now let's go to the side where we do not give a shock. Asystole or PEA, you off the bat have to give them epi. As we said, this is the dose. Continue CPR for 2 minutes, get IV-IO access, give them another epi, right, because it's every 3 to 5 minutes or 4 minutes, let's say, get that advanced airway, establish capnography, and check the rhythm again. They might have switched. If you see that they switch, then you go into this algorithm, and at any point, if this switches when you're checking, before you give the shock, you always have to check, right? If they go into here, then you have to stop this and you go to here. So any way you could go back and forth if they switch the rhythm. Now, if the rhythm is still, asystole or PA, then you just consider CPR and work on those H's and T's. And that is the algorithm for PALS.